Based on accessible ladder step 3. This session will be taken by Dr. Sunilkumar, who is a palliative care physician and is having 17 years of experience in palliative care. He did his fellowship in palliative medicine from Amrita Institute of Palliative, Amrita Institute of Medical Science, and diploma in palliative care and master in palliative medicine from Cardiff University. He is a national faculty of Indian Association of Palliative Care. Now he is working as a additional director of Trivandrum Institute of Palliative Science. Sir, welcome and over to you, sir.
Thank you, Shiva and Rajashmi. Good afternoon, everybody. Am I audible?
Yes, sir. Yes. Put off your mask.
Sorry?
Off your mask.
Able?
Sir, I think it's because of your mask, we are not able to hear it clearly.
Sounds are not coming clearly, no?
How is it now?
Yes, better, sir, better. Thank you.
So you all will ask me, you want me to take out the mask, which is against our ethics. Okay. Let me share my presentation. A presentation is visible, isn't it?
Yes, it is.
Okay. So we are going to talk about the strong opioids or opioids for moderate to severe pain, and how opioids act. What is the mechanism of action of opioids in case of pain? And many of us may have many doubts regarding the use of opioids when it comes to using opioids in patients. So we will talk about the practical aspects. And one of the main important aspects is we have to understand the adverse effects of opioids, which include side effects as well as toxic effects. So we will talk about that. And another problem which we usually see in not only in palliative care but in any other specialty is that patients often comes to us and I will tell you that I do not have proper relief of the symptom, and in that case you will increase the dose of the medicine or you will change it to another medicine, but we never inquire have you taken it properly. And if you have inquired that, many of the patients might tell you that that medicine is so costly and I am unable to afford that. And then patients will not have proper symptom control. So you need to understand the cost of or price of different opioids. We might write many opioids, but it is not knowing the price of opioids. If you know the price of different opioids, you will write the prescription according to that. So all of you know that this is the WHO analgesic ladder, which is a 3-step ladder. And from the second step onwards, we have opioids. And in the second step, you have opioids for mild to moderate pain. Whereas in the third step, we have opioids for moderate to severe pain. So I want this session to be interactive. And if you give the answer, we will go forward. If you know don't give answers, then we will start. So please be interactive. There is no wrong answers. It is always we say that's a scope to improve. So even if it is false, you can very well tell what's your opinion. So I would like to ask you, what are the opioids which are available to treat moderate to severe pain in India? Anybody can unmute and speak.
Morphine. Normally we are using morphine, no, sir.
Yeah.
Oral and
anything-
IV both.
Okay. Any other medications you know, or anybody else?
Sometimes we are using the tramadol also, no?
Tramadol, does it come?
With the combination?
Yeah. You mean Ultracet?
Yes.
Ultracet is a combination of tramadol and paracetamol. But
Fentanyl, sir.
yeah, thank you. Fentanyl. That's right.
Fentanyl patch, no, sir. Yes.
Morphine,
patch.
fentanyl.
Fentanyl IV also we are using, patches
Yeah.
also we are using.
Okay. Anything else in the third step of WHO analysis ladder? Strong opioid.
Ketamine?
Ketamine is not an opioid.
Okay.
Okay, that is methadone. Okay, so morphine, fentanyl,
Buprenorphine patch.
buprenorphine. Buprenorphine is not actually considered as a strong opioid, and its use is very much restricted due to many problems. So we rarely use buprenorphine because we have other medications which are better than buprenorphine. So in the third step, the opioids available in India are morphine, fentanyl, and methadone. Okay. And now we will move on to a patient story. Can somebody tell me what is the problem with this patient?
Toothache or something?
Patient
Okay.
is in severe pain. We can see with his facial expressions.
Okay, thank you, Renuka sister and Anandavashini sister. Anybody else would like to comment on this?
BP cuff is not in correct position, sir.
Okay, that was by Sister Subhana. Anybody else? Can you see a patient like that?
This is also not comfortable, sir.
Okay. So, what I wanted you to understand is if you see a patient like this, the first thing which we should notice is the facial expression of the patient. As Sister Anandavashini said us, the facial expression tells us that the patient is in severe pain. Okay. So this patient is a 56-year-old man with a carcinoma of the larynx. And his main problem is pain around his neck for the last 2 weeks. And it is the pain score is 10 by 10. That means the worst imaginable pain. And the patient says the pain is very sharp and it does not radiate to anywhere else. So this patient is in severe pain for the last 2 weeks, which is continuous in nature. And he is unable to sleep at night. So if you see a patient like this, how will you manage this patient?
By providing opiates.
Okay, thank you.
And after that, we have to keep him comfortable position and some physical arrangement for the patient's comfortable position to sleep and release the pain. And some counseling because he needs some physical things, I think.
Okay. So Sister Suraya told the opioids. Okay. So what would you use in this
Doctor,
situation?
maybe can do IV morphine titration immediately to settle his pain.
Okay, Vigneshwari. Vigneshwari, you are from which place?
No, good evening, doctor. Maybe can use for the to release the pain because the pain score is 10 out of 10. So for the immediate action, usually from my settings, doctor will do the IV pain titration for morphine. Based on
thank
the
you.
patient's kidney renal result as well. So
Okay.
either they,
Where are you from, Vigneshwari?
I'm from
What
Malaysia,
we-
Dr. Sunil.
From?
From Malaysia.
Okay, thank you. What Dr. Vigneshwari, Sister Vigneshwari told us, right? A patient is in severe pain, and in such situation, you know that a patient with severe pain, you have to use the third step of analgesic ladder, WHO analgesic ladder. So in the third step, we have opioids for treating moderate to severe pain. So you have to choose one of the strong opioids to treat this severe pain. So the most commonly and widely available opioid is morphine. And as you know, if you give injectable morphine, that will give faster pain relief. So you have to do something called as intravenous morphine titration. Okay. Vigneshwari, how do you do an intravenous morphine titration? Can you tell us?
Usually, doctor, usually we will titrate the morphine 1 in 10 with normal
Okay.
saline. So
Okay.
based on that, our role is just prepare the medication, dilute the medication, morphine 1 in 10. Then usually doctor is the one will give the titrate the patient. So by meal, they will observe, they will give the patient, and then observe and check whether patient the pain is reduced or not. So based on the patient reaction, the pain relief, they will stop immediately. So let's say maybe until 4 mg given, so patient pain is controlled. So from there, they will stop titrating and observe for the patient's sign and symptoms.
Okay. Thank
Sometimes
you.
patient relief from immediate pain, and then patients start falling sleep as well. They will start falling sleep lah. This
Okay.
is what I
Thank
have
you.
observed usually, doctor.
Okay. So what you told is almost correct. We will see. Okay. So you can see this patient after morphine trial, how he looks like. Okay. So this was the first scene when you saw the patient in severe pain, and after maybe some 45 to 60 minutes after the morphine trial, patient is smiling at you. So this magic was made by intravenous morphine titration or intravenous morphine trial. So how do you do intravenous morphine titration? So you have to give injection morphine 1.5 milligram at 10 minutes interval. So you will give 1.5 milligram of injectable morphine intravenously every 10 minutes. So I think the strength of injection morphine ampules available in different settings would be variable. For us, it is 15 milligram of morphine in 1 ml. So we will dilute 1 ml of morphine with 9 ml of normal saline. So total 10 ml. 10 ml contains 15 milligram of morphine. And from this, if you take 1 ml, that will be equivalent to 1.5 milligram. So that's how you give injection morphine 1.5 milligram intravenously at 10 minutes interval. So what is the immediate side effect that you are expecting when you administer intravenous morphine in this dose? Anybody?
Vomiting, sir.
Yeah, it's nausea and vomiting. So you have to give an antiemetic before you start injection morphine. So it is usually injection metoclopramide 10 milligram IV is given first, followed by the first dose of morphine. Okay.
Correct.
And what would be the end point of injection morphine titration, or when would you stop giving injection?
Respiration, sir, that because patient is some larynx cancer, no?
Yeah. So, Renuka, I didn't get you. What did you mean?
Sister Renu, can you repeat what you said?
Sorry?
Can
Uh,
you
yeah, can you repeat what you were talking? You were talking about carcinoma larynx, something like that.
No, is having some larynx cancer, no? We have to be careful about the respiration things, no, sir? The morphine IV, we are giving that because of
Okay.
that respiratory depression can be cause
Yeah,
some bad
yeah,
effects to the patients.
I understand your concern. Yeah, we will talk about that later. But for the time being, what would be the endpoint of morphine titration, or when would you stop giving injection morphine?
Okay, okay. Thank you, sir.
Yeah. Anybody?
Patient also can have severe weakness.
Hmm. Okay, thank you, Dr. Sister Philo. The endpoint of morphine titration is either the patient should have satisfactory pain relief or the patient develop sleepiness. Okay, whichever be the first. So this is where you will stop giving injection morphine. Either the patient should have satisfactory pain relief or the patient should develop drowsiness, whichever be the first. So we will take a example. So this is how IV morphine trial you can record. You will have time, pulse rate, respiratory rate, blood pressure, pain score of the patient, if the patient drowsy or not, what is the dose of injection morphine you have given. Suppose this patient came to us at 10 a.m. You will check the vitals. Pulse rate, it is 90. Respiratory rate, 22 per minute. Blood pressure is 140/86. You asked the pain score, patient says it is 10 by 10. So you recorded it is 10. The patient is not drowsy. So you recorded no. And then you will give injection morphine followed by first dose of injection morphine. That is 1.5 milligram you will give. And then you will wait for 10 minutes. So that's what I told you. Injection morphine 1.5 milligram has to be given every 10 minutes. So at 10:10, you will again check all the vitals. You will ask the pain score of the patient. Patient says it is 7 now, and the patient is not drowsy. You will give again 1.5. So at 10:30, when you examine the patient says now my pain score is 1. That means patient has good relief of pain and the patient is not drowsy. So as the patient has got good pain relief, so this is an indication to stop the morphine trial. So you stop the morphine trial. Okay. So how many milligrams of morphine was required for this patient for pain relief?
5 milligrams, sir.
Not 5 milligrams, it is 4.5, isn't it? 3 doses of 1.5. So that is 4.5 milligram. So with 4.5 milligram, this patient has got good pain relief. So I just want to ask you another question. Is this intravenous morphine titration it's an inpatient procedure or outpatient procedure? Anybody? So you can do this as an outpatient procedure. You need not make the patient inpatient. Okay. So you want to actually the patient wanted to go home because he has good pain relief. So with 4.5 milligram of IV morphine, he got good pain relief. Now you want to send the patient home. So you need to convert this intravenous morphine to oral morphine. So how many milligrams of morphine would you give orally for this patient?
Five mg QID.
5 mg QID. Okay, Suraya. Anybody else?
15 milligram TDS.
Okay, Renuka, can you tell me why it is 15 milligram?
The patient is in cancer, no?
Yeah. Yes. So,
According to the body weight, normally 4.5 milligram IV. And in oral, I think that's normally we are giving like.
okay. Okay, thank you. But okay. So when you give
10 mg QID.
okay, thank you, Nilo, for your comment. But you can see that this was a study conducted in 2000 by our chairman, by Dr. Najagopal MR and his colleagues. This was intravenous morphine for emergency treatment of cancer pain, which was published in Palliative Medicine, Journal of Palliative Medicine. And what we found out was the approximate 1:1 ratio. That is, initial intravenous morphine dose is to first oral dose in a ratio of 1:1. 1:1. That means whatever you have given intravenously and that has given good pain relief, you can start the same dose orally. That means this patient got good pain relief with 4.5 milligram of morphine. So you can start this patient on 4.5 milligram of oral morphine. But 4.5 milligram of oral morphine is not available. The nearest available strength of morphine tablet is 10 milligram. So you can break the tablet into two so that each half becomes 5 milligram. So you can start this patient on 5 milligram of oral morphine. And how frequently you need to give oral morphine? And what is the duration of action of oral morphine? So it is only 4 hours. The duration of action of morphine is 4 hours. So you have to administer oral morphine every 4 hours. Okay. So this is how you will administer inject tablet morphine. So for this patient, we need 5 milligrams. So you will give 10 milligram half. So instead of wake up, say it is at 6 a.m., then you can give the next dose at 10 a.m. It is 4 hour interval. Then 4 hour, it is 2 p.m. Then next is 6 p.m. And at bedtime, you will give double dose of the regular dose. So it is 5 milligram regularly you are giving, but at bedtime, you will give double dose, that is 10 milligram. And this is the normal dosing of morphine. 6 a.m., 10 a.m., 2 p.m., 6 p.m., and 10 p.m. 6, 10, 2, 6, and 10 p.m. But in addition to this regular dose, you can also provide or give SOS doses of morphine, which is as equal to the normal dose. This patient is taking 5 milligram normally. So he can take 5 milligram if he has pain in between these doses. Okay. And why I have written when the patient wakes up is that you know that most of the patients who are in pain will be getting some sleep by early morning, and they will be sleeping at 6 a.m. So you need not call the patient to take morphine at 6 a.m. Let them sleep, and you can give first dose of morphine when he wakes up. And likewise, the patient need not wait till 10 p.m. to take the last dose. Rather, you should give the morphine, the double dose of morphine when the patient wants to go to sleep. So that's why it is written as a bedtime instead of 10 p.m. Okay. And if you do not have intravenous morphine or injectable morphine with you, then you have to give oral morphine trial for the patient. So how will you give oral morphine trial? So if a patient is not on any opioid and if he has severe pain, then you can start the patient on 5 milligram of morphine for hourly and SOS. Okay, that is opioid naive. And if the patient is taking or if the patient is on any weak opioids like tramadol, codeine, then you can start the patient directly on 10 milligram of morphine for hourly and SOS. Okay. So this is how you will give oral morphine. So now we have our patient, Mr. X. We started him on 5 milligram of oral morphine every 4 hourly and SOS dose. So you have given an intravenous morphine titration, and you found that 4.5 milligram of morphine was effective in pain relief. So you started him on 5 milligram of morphine 4 hourly and SOS. And this patient had very good pain relief. But after a few weeks, then patient started to take more SOS doses in addition to the regular dose. So you can see he was taking 4 SOS doses of morphine per day for the last 4 days. So what shall we do now? Anybody? What should you know? What should you do now?
We should increase the dose now.
Increase the dose, sir.
Okay, how much would you increase the dose?
It can be 1, like double the dose. Instead of 5, we can give us 10.
Okay.
10 mg 4 hourly.
Okay, and how frequently would you give SOS dose of oral morphine? Or how many times you can give SOS dose of oral morphine?
Twice,
Okay, so we'll see.
over 24 hours.
Okay, thank you. This patient is taking 4 SOS dose of morphine. Why he is taking 4 SOS dose of morphine? His pain is increased and his opioid requirement has increased. That's why he is taking 4 SOS dose. So that means this patient who is taking 5 milligram 4 hourly with 4 SOS dose, now we need to increase the normal dose. Okay. So how much would you increase? You can increase the dose by 30 to 50%. Okay. So in this patient, 5 milligram. What would be the 50% of 5 milligram? It is 2.5, isn't it? 5 milligram into 50% is 2.5. So you can add 2.5 to the normal dose. That is 5 milligram is the normal dose plus 2.5. That is
7.5.
7.5. Yeah. So you can increase up to 7.5 milligram. But some patients would find it very difficult to break the tablets into 4 pieces because you have only 10 milligram tablets, and breaking it into 4 pieces would be difficult. So in such instances, even you can advise 10 milligram for hourly. But as a general rule, you can increase the dose by 30 to 50% if the patient is taking 2 or more than 2 SOS dose. PRN is same as SOS dose. So if the patient is taking more than 2 SOS dose, increase the dose of opioid by 30 to 50%. Not every 2 to 3 days, you can actually increase the dose every 24 hours. And how frequently would you give SOS dose of oral morphine? So Sister Anandavashini told twice a day. Let us see. So what happens? So this is the morphine plant, which is known as poppy plant, or scientific name is Papaver somniferum. Okay, and this poppy plant is grown legally only in 3 states of India. Okay, so that is UP, MP, and Rajasthan. So these are the only 3 states in India who can legally grow opium or opium poppy plant. And you can see the seed-like things which are known as pod, POD pod. And you can see the farmers make small cuts on this pod, and the sap is coming out. And this sap is collected and dried in sunlight. And this is then transported to government opium and alkaloid factories, from which they will make morphine powder. Okay, this is how morphine powder And this morphine powder, then the pharmacies, different pharmaceutical companies, they make morphine tablet, injection, etc. out of it. And once you swallow, the tablet, this is absorbed from the upper small intestine. So the tablet is absorbed from the upper small intestine, and morphine is hydrophilic. That is, it is water soluble. Okay, so you can actually make a paste of morphine if the patient is unable to swallow, and ask the patient to maybe have some water and take it. And these are something which you need to understand. Some people would say that morphine can be administered sublingually, but it is not absorbed commonly, or it is not absorbed normally from the sublingual route. So it is advised not to give morphine sublingually. You have to keep the morphine sublingually for longer time. We don't know how long. And sometimes patient may say that after putting the morphine sublingually, I got good pain relief. Then what you have to understand is the patient has swallowed it. That's why the patient has pain relief. And buccal as well as gingival route is also not advisable. And when you make the morphine powdered, when you powder the tablet, it has a bitter taste. So when you administer powdered morphine to patients, remember to sweeten it with sugar or fruit juice. And what happens to the swallowed tablets? It will go into the gastrointestinal tract, and from the upper small intestine, it will be absorbed into the blood vessels of intestine. Okay. Then from the blood vessels, it will go into the portal vein. From portal vein to liver. And as you know that metabolism of morphine takes place in the liver. And morphine will be converted into various parts or various metabolites. And these metabolites are then liberated into the systemic circulation. And this metabolite will give you the pain relief. So the metabolism of morphine takes place mainly in liver, and 90% of morphine is converted into metabolites. That means 10% may bypass the liver. And morphine is converted mainly into two metabolites, which are, in short, it is known as M3G and M6G. That is morphine 3 glucuronide and morphine 6 glucuronide. You can see the morphine 6 glucuronide is formed in small quantity, only 5 to 10%. But the importance is that this component, that is M6G, is the active component or active metabolite which will give you the pain relief. M3G doesn't have much action in our body, but it may cause some neurotoxicity like delirium, myoclonus, etc. So the active component which will give you pain relief is M6G or morphine 6 glucuronide. So what you have to understand is you have to swallow the tablet. It has to go into the GI tract. Then it is absorbed into the blood vessels of GI tract. Then it goes into the portal vein. From portal vein to liver. And in the liver, metabolism takes place. And the metabolites are liberated into the systemic circulation, with which the patients will have pain relief. So this process will take some time. So the patient will start to get pain relief by 30 minutes. But the peak of analgesia will be by 1 hour if you give morphine by oral route. So it is always better to wait for 1 hour before you give the next dose of morphine. So how frequently you can give SOS dose of morphine? It is after 1 hour of the previous dose. So that's the answer. There is no restriction like 2 doses or 3 doses. So theoretically speaking, you can give morphine 24 doses because we have 24 hours a day. So first you give morphine and then wait for 1 hour. Patient doesn't have pain relief, you can administer another one. So that's how you have to administer morphine. even though the normal duration of action is 4 hours. Okay. So again, our patient, you know that he had severe pain, and we increased his dose to 10 milligram every 4 hours. But the patient says, sorry, I cannot take it every 4 hours. You know that many of the patients says, I have to take a handful of medication, and every hourly I have medication. So it is very difficult for me to remember. So is there any way that you can give it less frequently? Please find out the answer. I am waiting for one. Okay. So what is your option if the patient is saying like this?
Sir, can he go for like IV morphine trial?
Why do you want to give IV morphine trial? Because we gave the patient IV morphine trial and then we started him on 10 milligram. Here the problem is that the patient has good pain relief. Patient says, I have good pain relief. But the problem is that he is unable to take it every 4 hourly because he sometimes do not remember it. And I don't like to take it every 4 hourly. And if I ask some of you to take amoxicillin every 8 hourly, how many of you will take it? How many of you will complete 5-day course of amoxicillin? Including me, it will not be completed. So we know that how difficult it is to take every 4 hourly. So that's the problem with the patient. So what would you
SOS, he can go for the SOS only. SOS 10 mg.
SOS 10 mg, okay.
Or
Shwan,
Can't
Can
we
we-
give 10 milligram? Sorry. Okay.
yeah, patient is taking 10 milligram every 4 hourly.
Can
But
we
he
convert to the patch?
give 20 milligram BD or TDS? No, 15.
Okay. So you have bright ideas. But what you have to understand is when you give 20 milligram every 8 hourly, then the patient is going to be drowsy. So our aim of pain relief is that, or our aim of giving morphine to the patient is that the patient should be active. They should be able to do everything that is possible for them. So if you give 20 milligram, patient would be drowsy and they will not be active, and that's not good for the patient. So that's not an option. And the patch, morphine patch is not available. And if you give only SOS dose, the patient will be in pain. What else is the option?
Sir, can we give 10 milligram TDS and some PRN doses like in between?
And the problem is that the patient need 10 milligram every 4 hours. So if you make it 10 milligram 8 hourly, the patient will be having severe pain.
Yes.
Okay, we will see. There is something called a sustained release morphine tablet. Okay, sustained release or controlled release morphine tablet. So what is the duration of sustained release morphine tablet? It is 12 hours. Okay.
In 15 milligram, no, sir?
Yeah. It is not 15 milligram. This patient is, okay, we will come to that. The duration of action of sustained release morphine is 12 hours. So you need to give only twice daily, BD. So our patient was taking 10 milligram every 4 hourly. That means, what is the total dose of morphine this patient is taking? 10 milligram 4 hourly?
60 mg total.
Yeah, 60 mg. So 60 mg per day. That is 60 mg over 24 hours. So when you convert this into sustained release morphine, you have to divide it into half. So 30 milligram BD. SR morphine. That will come to total 60 milligram per day. Okay. So we have converted 60 milligram instantaneous release or fast acting morphine into SR tab morphine SR 30 milligram BD. But you have to also understand is when you give morphine SR, then can have pain in between. So you also need to provide an option of taking SOS dose of morphine. But SOS dose of morphine is not sustained release. You should not give sustained release. You should give only the normal morphine, that is fast acting or immediate release morphine. And the dose is same as previous, that is 10 milligram. Okay. So what are the preparations of morphine available? So we have syrup or aqueous solutions, tablets and capsules. That is in both forms, immediate release as well as controlled release. Immediate release tablet, duration of action is 4 hours, whereas controlled release tablet, duration of action is 12 hours. Then we have injection, which comes in 1 ml ampules and contains 15 milligram of morphine, 1 ml. Okay, so now we are moving on to the patient, the same patient. So we have started this patient on 10 milligram every 4 hourly, and for the past month, for 6 months, the patient was stable. He had very good pain relief. He didn't need to visit us, but on a fine day, he come to casualty with excessive drowsiness, and you sent some investigations. The doctor has sent some investigations, and he found out that total count is 13,000, blood urea 20 milligrams per deciliter, serum creatinine is 5 milligrams per deciliter. And will you do anything with morphine dosage? Or do we need to do anything with morphine dosage? So you can see this patient is excessively drowsy. Why this patient is excessively drowsy?
Because of the blood urea and the morphine effect of both.
Blood urea is normal, isn't it?
That's so much.
Creatinine,
I think it will be due to
He must have taken a double dose or something. The time or it may not be 4 hours. He would have missed and taken it together.
okay, yeah, those are the postulative. But what we have to understand here is how morphine is eliminated from our body. Okay, so morphine is excreted or eliminated from our body by glomerular filtration or through urine. Okay, so morphine is filtered out by the kidney and it is excreted through urine. So if the patient has renal failure, what happens? This patient has a serum creatinine of 5 milligrams per deciliter, which means the kidney is not functioning properly. So what will happen if the kidney is not functioning properly? The morphine is not excreted from your body, and whatever you are giving, it is getting accumulated in your body. So when morphine gets accumulated, that will cause drowsiness. Okay, so that's why this patient becomes drowsy. So this is very important. Whenever a patient is having renal failure or chronic kidney disease with elevated serum creatinine, you have to be careful. So this patient, what you have to do is, instead of 4 hourly, now you can give morphine maybe 8 hourly or 12 hourly, depending on the serum creatinine. And even you can reduce the dose of morphine from 10 milligram, you can reduce it to 5 milligram. So this is one instance where morphine is not given every 4 hourly. It is given maybe 8 hourly or 12 hourly or even once daily in patients with who are undergoing hemodialysis. Or you can give opioids which are supposed to be renally safe. So methadone and phenanyl are 2 opioids which are supposed to be renally safe. Okay, so we started the patient on 5 milligram every 8 hours because he had renal failure. And the patient was comfortable for a few months. And after that, this patient was unable to swallow anything, including morphine. And the patient is at home. And probably he is terminal. He's going to die in another few days. And that's why he is unable to take it anything orally. So what will you do now for pain relief? What would you do?
Can be any other symptomatic relief apart from morphine.
What will you give?
Can we use any other like injection tramadol, any other painkiller?
Yeah, that's an option, but it may not give such pain relief.
What about fentanyl patch, doctor?
Fentanyl patch. Okay. Anything else?
Subcut injection.
Yeah. So answer is subcutaneous injection of morphine. But this patient is at home. And injectable morphine.
Powder form to given, sir.
But patient is even unable to take water.
Patient is at home, no, sir.
Yeah. He's not
We
taking
can't give
anything
morphine
orally.
infusion, no.
Would you give injection morphine to the patient's home? Would your hospital allow to give injection morphine when the patient is at home? We do give injection morphine at patient's home, but most of the hospitals in India won't allow to send injection morphine to patient's home.
In Sri Lanka, we are not giving home injections, sir.
Okay.
Like infusions, morphine infusion, like no.
Okay.
Yes,
Yeah.
they have to come to the hospital to take the morphine infusion and all of this.
Yeah.
Even
So you know that-
subcut injection we are not using at home. We can't practice.
Yeah, it is very difficult for this patient because this patient is going to die in a few days, and it is very cruel to ask this patient to come to hospital for getting this injection. So what else can be done? Okay, for this we have to understand what are the routes through which you can administer morphine. So you know the most common route is oral, and then intravenous or subcutaneous. What are the other routes through which you can give morphine?
Sublingual, sir.
Sublingual, I already told you should not try sublingual morphine because it is not absorbed sublingually. What else?
Subcutaneous.
You can give morphine parectally. Okay. Then epidural, intrathecal. So in this patient, we can administer morphine parectally. Actually, parectal route of morphine, it is as equal to oral route. How much you are administering orally, that can be administered parectally. Same amount of morphine in the same duration, the effect will be the same. Okay. So for this patient, 5 milligram 8 hourly who is taking orally, you can administer 5 milligram parectally every 8 hourly. But the only thing is that you need to make the morphine as a paste. So take 5 milligram of morphine, add 2 drops of water, make it a paste, and then do a parectal examination and rub it over the rectal mucosa. That's all what you need to do. And this has to be done every 8 hours. The patient will have good pain. And now we will move on to another patient. This is a lady, Mrs. K, who is a 55-year-old lady with carcinoma of the colon. Has abdominal pain, which is continuous in nature. And this patient is on 10 milligram of morphine every 4 hourly. And with this dose, she has very good pain. And this is another patient who says, I don't want to take it every 4 hourly. So the doctor asked to replace the morphine with a fentanyl patch of 25 microgram. Okay. And but the next day the patient comes to you and tell you that doctor, I didn't have pain relief. So I removed the final patch yesterday itself after 5 hours of application. So what are you going to do for pain relief in this patient? Anybody?
Maybe we can explain to the patient first that the fentanyl patch is actually need to take 12 hours to then only it will have the effects. So within the 12 hours before the effects started from the patch, she can actually continue the morphine 4 hourly first until the patch effects start.
Agree.
How many hours will it take, Swan?
4 hours, doctor?
Now, how many hours will the fentanyl patch take to give you the pain relief?
Oh, 12
72
hours.
hours, no, sir.
6 hourly once.
6 hourly?
Sir.
Oh, I mean, in Malaysia, the once we put the patch, after 12 hours later, then only the effect will start and it's actually lasts for 72 hours.
Okay. Yeah. So many of the patients and the caregivers, usually the people who write or prescribe fentanyl patch, they will not teach the patient about fentanyl patch. But there are few things which you need to teach. So what are those points? So one is that once you apply the fentanyl patch, it will take about 8 to 12 hours to get pain relief. And how fentanyl works? Once you apply the fentanyl patch, fentanyl is absorbed into the subcutaneous tissue. And in the subcutaneous tissue, they will make a storage. Okay. And from this storage, fentanyl will be liberated into the systemic circulation every hourly. So, sorry, sir, there is some disturbance here. So, for the subcutaneous tissue storage or subcutaneous tissue depot to develop, it will take about 8 to 12 hours. So that's what you have to understand first. So till this 8 to 12 hours, actually the patient need to continue the previous opioid which he or she was taking. So in this case, the patient was taking morphine 10 milligrams. So you have to ask the patient, even if you apply the patch, continue the morphine for another 8 hours. So the patient need to take 2 or 3 doses of morphine. Then they can stop. And then the fentanyl patch will take over. Okay. So these are something which you need to teach the patient. And there are other few points. As Swang told, its duration of action is 72 hours. So you have to replace the fentanyl patch every 3 days after 72 hours. And when you apply the fentanyl patch, you should not shave the area, because if you shave the area, there will be small abrasions or wounds in your skin, which will increase the absorption of fentanyl. And if the patient has fever, that is also going to increase the temperature. And you should also ask the patient not to take hot bath, or they should not go to the hot places, because that is also going to increase the absorption. And you know that fentanyl patch can liberate only constant amount of fentanyl. 25 microgram means every hourly it will liberate 25 microgram of fentanyl. 50 microgram patch means every hourly 50 microgram fentanyl will be released. So we cannot alter the concentration of the fentanyl that is liberated. So it is not suitable for patients who has unstable pain. That means those patients who have frequent ups and downs in pain, we should not use fentanyl patch. Okay, so this is suitable only for those patients who has a stable pain. That means you have given opioid and the patient, maybe you are giving morphine every 4 hourly, and the patient doesn't need much SOS doses of morphine. He need once in a while SOS dose of morphine. So such patients, you can convert it into fentanyl patch. But the thing is that it is very costly. Compared to morphine, it might be very maybe 100 times or 200 times more costly. So these are the preparations of morphine fentanyl available. It is available as injection, then transdermal fentanyl patch, and it is also available as transmucosal fentanyl citrate. That is something like a lollipop, and you can rub it over the oral mucosa, and that will give instantaneous pain relief. So it is suitable for patients who has short-acting pain. And fentanyl is 100 to 150 times more potent than morphine. And if you calculate with this 100 times more potent than morphine, then 60 milligram of oral morphine per day would be equivalent to 25 microgram per hour fentanyl patch. So 60 milligram of oral morphine is equivalent to 25 microgram patch. And if the patient is, if you want to convert a patient who is on 120 milligram of oral morphine per day, that would be equivalent to how much of fentanyl? $120 milligram of oral morphine. Patient is taking 120 milligram of oral morphine. You were asked to replace it with a fentanyl patch. What would be the strength of fentanyl patch that you are going to use for this patient?
50.
Yeah, it's 50. 60 milligram is equal to 25 milligram. So 120 milligram is equal to 50 microgram.
50 microgram.
Yeah. Okay. So now we'll move on to another patient. This is a patient, Mr. P, 70-year-old man, has carcinoma of the lung and is complaining of throbbing pain on right front of chest, which is continuous in nature, and his scores 5/10. He is a non-epileptic and is also on levetiracetam 500 milligram BD. That is an anti-epileptic medication. How will you manage this pain? Anybody?
We can go for a 25 microgram fentanyl patch over the chest.
Okay. Anybody else? What is the severity of the pain here?
5/10.
5/10. So which step of WH analgesic ladder this patient needs?
Step 2.
Step 2.
Weak opioids.
So which one would you select?
Tramadol, injection tramadol.
Yeah. So that's what you have to see. Here the pain, it's 5/10. So you can maybe 0 to 3, you can say it is mild pain. 4, 5, 6, moderate pain. 7 and beyond, it is severe pain. Okay, so this patient has moderate pain. So you have to select the second step of WH analgesic ladder. So in the second step, we have opioids for mild to moderate pain. So that is tramadol, tapentadol, codeine, dextropropoxetine. So these are the few opioids which are available in the second step of WH analgesic ladder. So is everybody comfortable with tramadol? Or any of you have any difference of opinion?
As because tramadol, when we are giving IV, we have to be very slow. because that might cause immediate nausea, not nausea, even patient can vomit if we are not giving it very slow. So we have to be very careful when you are giving IV tramadol. It should be very slow.
Yeah, that's true. Not only in case of tramadol, but any other patient on opioid can have nausea and vomiting when you introduce it for the first time. But tramadol has more tendency to produce nausea and vomiting. Anybody else have any more concerns? So another thing which you need to understand is tramadol is a medication which can reduce the seizure threshold. Okay. Tramadol can reduce the seizure threshold. That means it can precipitate a seizure. So you can see this patient is already a non-epileptic. And if you give tramadol, then there is a chance that that can precipitate a seizure in this patient. So if the patient has any non-risk factors for seizure like epilepsy or patient with a brain metastasis, then it would be better now to start the patient on tramadol. And if you give injection, you should be very, very careful because the fast IV push of tramadol can precipitate seizure. So whenever you give tramadol, you should be very, very careful. So if possible, avoid and if not, give it maybe orally. So tramadol is not a choice here. Maybe you can even give low dose of morphine here. Okay, maybe 2.5 milligram. So how does the opioids act in our body? So opioids act in our body through opioid receptors. Okay. So the opioid receptors are mu, kappa, and delta. These are the three opioid receptors present in our body. So when they combine with these receptors, there will be neurotransmitter changes in our body, and that will help to give us pain relief. Okay, and this opioid receptors are present entirely in our nervous system, not only in the central nervous system but also in the peripheral nervous system. But it is abundant in central nervous system, and this is something which you can have just have a look. Opioids can be classified based on the action on opioid receptors into three. That is agonist, antagonist, and agonist. Agonist opioid means when an opioid combines with opioid receptor, it will produce physiological action. That is known as an agonist. Physiological action means pain relief. It is when the opioid receptor combines with when opioid combines with opioid receptor, it not only gives pain relief, but also it produces some other action like constipation and many other things. So that is known as an agonist. Agonist antagonist means this opioid acts as an agonist on certain opioid receptors, but it also acts as an antagonist on other opioid receptors. So the examples of agonist and antagonist are buprenorphine and pentazocine. Okay. And antagonist means antagonists work only in presence of an agonist. If you give an antagonist to somebody who is not taking opioid, it doesn't have any action in your body. It acts only in presence of an opioid. So antagonist will reverse the action of an agonist. So antagonist example are naloxone and naltrexone. And most of the opioids like the methadone, fentanyl, morphine, those are agonist opioids. Okay. So please see this graph. The first one is for agonist and second one is for agonist and agonist. So in the first graph on the x-axis, it is the dose of opioid you have given, and y-axis is the pain. Suppose in the agonist, take morphine. You have given a patient 5 milligram of morphine. This patient has pain till here. Okay. So this is the pain level of this patient. And you have given this much 5 milligram of morphine. That will give this much pain relief. When you increase the dose, that will give corresponding increase in pain relief. And when you increase the dose till here, this much, then you will have complete pain relief. That means when you give an agonist for a patient, there will be corresponding increase in pain relief, or theoretically the patient should have 100% in pain relief. But in case of agonist and agonist, what happens? You increase the dose of agonist and agonist, that will give corresponding pain relief. But it is up to a point. You can see till this point, when you increase the dose, that will give corresponding pain relief. But after this, even if you increase the dose, it will not give corresponding pain relief. Okay. So this effect is known as ceiling effect for analgesia. Agonist and agonist have ceiling effect for analgesia, whereas agonist doesn't have ceiling effect for analgesia. So this is the main difference between agonist and agonist and agonist. So agonist and agonist, I have told you two examples are buprenorphine and pentazocine. So now we'll move on to adverse effects of opioids. Adverse effects of opioids can be divided into side effects and toxic effects. And so can somebody tell me what are the side effects of opioids?
Constipation.
Nausea, vomiting.
Okay.
Right, please.
Yeah. Anything else? So as you told, side effects means these are the adverse effects with the therapeutic doses. So you have given morphine to a patient. The patient have very good pain relief. I told you when morphine combines with the opioid receptor, it not only produces the pain relief, it also has some other action. So these are the other actions. It may produce constipation, it may produce nausea and vomiting, sleepiness and tiredness, itching sometimes, dry mouth, urinary hesitancy. The first three are common side effects, whereas the next three are rare side effects. And most common side effect is constipation, and almost all patients will have constipation. And the peculiarity is that as long as the patient is on opioid, they will have constipation. So when you prescribe an opioid, you should also write a laxative. It is the choice of laxative is stimulant laxative. Okay, there are many types of laxative, but we have to give stimulant laxative. So the example of stimulant laxative is bisacodyl, senna, or sodium picosulfate. So don't forget this. Then nausea and vomiting, and it occurs in about 30% of patients. But here the nausea and vomiting will be there only for the first few days, maybe up to 3 to 5 days, or maximum of a week. It is self-limiting. But constipation, it is there for lifelong, as long as the patient is on opioid. Here, after 3 to 5 days, nausea and vomiting will be relieved, even if you don't give any antiemetic. And this nausea and vomiting is due to stimulation of chemoreceptor trigger zone, which is an area in the brain. Okay. So opioids stimulate this area, CT, and that produces vomiting. So what would be the choice of antiemetic in patients with opioid-induced nausea and vomiting? You can give haloperidol, metoclopramide. Haloperidol or metoclopramide. This is the drug which can relieve actually nausea and vomiting. And sleepiness and tiredness. This also occurs in almost 1/3 of the patients, but maybe within 3 to 5 days or maximum of 7 days, that will be relieved. It is self-limiting. You need not do anything. And now we'll move on to toxic effects. What are toxic effects? These are the adverse effects when the administered dose is higher than the required for pain
Sir,
relief.
your slide is not moving.
Rajlakshmi, can you see?
Yes, sir. Your slides are
Even
not moving,
side,
sir.
Not moving?
side effects.
Not moving, sir.
Yeah.
Can you-
Then moving here. How is it now? Is it moving?
Sir, no, sir. Can you stop share and share it again, sir? We will see.
Okay. Are you able to see now?
Yes, sir. Slide on toxic effect.
Okay.
Yes, sir.
So toxic effects means these are the adverse effects when the administered dose is higher than the required dose for pain relief. So how do you know these are toxic effects? So if the patient has delirium means irrelevant speech, or myoclonus means it is the jerky movement of the body, or patient become extremely drowsy. So these are the signs and symptoms by which we can understand that the patient has toxic effects. If the patient has toxic effects, what you have to do is you have to reduce the dose of morphine. Okay, suppose you are giving 10 milligram every 4 hourly, you might reduce it to 5 milligram 4 hourly. That's all what you need to do. You did not do anything else. And this was something which you were concerned with morphine, opioids producing respiratory depression. But the evidence say that this is very, very rare, especially when you give morphine orally or opioids orally. So it says the chance of respiratory depression is very unusual because we start with oral dose and we gradually increase the dose, which ensures that respiratory depression will not happen usually. And if there is respiratory depression, then you should look whether the patient has a pneumonia or pulmonary embolism or cardiomyopathy, or are you co-administering benzodiazepine along with opioids. So please be um, please understand that the respiratory depression with usual doses of opioids which are given orally, usually it is, I have not seen any case of respiratory depression during the last 20 years of my career in palliative care. I have prescribed morphine for maybe some 25,000 patients, and injectable morphine or injectable fentanyl for thousands of patients. But I have not seen any patient with respiratory depression. So if you know how to give injectable morphine and oral morphine, you will not produce respiratory depression. And this is another concern for most of the medical professionals, opioids producing respiratory depression. Addiction. So what is addiction? Addiction, there are two types. One is known as physical dependence, and the other one is known as psychological dependence. Psychological dependence is known as addiction. Okay. So addiction, it is defined as a, you can see, primary chronic neurobiologic disease. So it is a disease in which individuals who are genetically predisposed. So there are some genes for addiction. So addiction is a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestation. So that means if you have a gene for addiction, and if one of your friend is an addict, and you are working in an operation theater where a lot of opioids are available, then your psychosocial and environmental factors become favorable. So you have a gene for addiction, and then there's a chance that you may get addicted. Okay, but the when you use it for medical purpose, like for treating pain, the chance of addiction is very, very low. Okay, and physical dependence. I would ask you a question. Suppose how many of you take coffee in the morning? Some of you, yeah. So think one morning you do not get coffee. Huh? How would your body will react?
I have not been like addicted. I can skip my coffee, take a tea. Yeah, a little late also. But one of my friends, she was like almost addicted because without tea, she cannot go clear her,
Bowel.
bowel. Yes. So she has
And
to take the tea. Yeah.
and some of you will have. Do you get headaches, yawning when you don't get coffee?
Yes.
Irritable. Is it addiction? You are addicted to coffee. It's not actually a psychological dependence. That is known as physical dependence. Okay. So you were giving coffee to your body for the past 30, 40 years. And one day, fine morning, you are saying, no, today I am not going to give you coffee. So your body is asking, why you are not giving coffee to me today? And the body is asking by these symptoms, some headache, irritable, yawning. Those are some ways the body reacts. Okay, and those are known as withdrawal symptoms. Okay, and this indicates you have a physical dependence. But if you have psychological dependence, that means addiction, you would have gone to the next house which was locked. You would have broken the lock and enter the house to get coffee powder and sugar to make coffee. If you do that, you have psychological dependence. But you don't do that, isn't it? You will think, okay, tomorrow I will get coffee. So you can, um, your body has some reaction which is known as withdrawal reaction. That is because you have physical dependence. You do not have psychological dependence. So psychological dependence, you have craving. You will do whatever possible to get that. Okay. So that's the difference between physical dependence and psychological dependence. So you can see here there is impaired control over drug use, and you know that this will cause more of harm to you, and you have craving for the same. And we know that there are some medications like dexamethasone or any opioids. If you have given it for 3 weeks, would you stop it abruptly? No, you will not stop. You will reduce the dose and taper the dose and then stop. That's how you are stopping the opioids. Why? It can produce some physical dependence. Okay. And now we will move on to the different prices of opiates. You can see that a patient who is on 5 milligram of morphine every 4 hourly. So totally he will need to take 30 milligram. 5 milligram 4 hourly means it is 30 milligram. And for 30 milligram, the cost would be 3 rupees 50 paise per day. But to get the same pain relief, you have to take 300 milligram of tramadol, and the price would be between 24 to 50 rupees. Whereas to get the same pain relief, you have to use 12.5 microgram of fentanyl patch, and the price is 250 to 400 rupees per 3 days. And if you use buprenorphine patch, then this is the cost, 1000, about 2000 for 2 weeks. And if you use methadone, it will the cost is almost same as morphine. So this is the comparative cost. So many of you might be knowing about the fentanyl patch, buprenorphine patch, but please understand that this is going to be a more costly affair And if you prescribe it to a poor patient, they will not take it. And it's our duty to see that our patient is not suffering. They will get some pain relief from us. So morphine and methadone are the two drugs which is the cheapest in India. Okay. So I think I will stop here. And yeah.
So can we start our case presentation?
Okay.
Sister Renuka? Sister Renuka, can you hear us?
Hello. Yeah.
Yes, ma'am. You can start your presentation.
Can you share me the slides? Can you can share now?
I have already shared it, ma'am.
No, I can't see.
So can you see?
Yes. I'm Renuka from Sri Lanka. I'm working in Lanka Hospital. It's known as, I think, Apollo. Yes. Today I'm going to talk about some 7 years male boy diagnosis, Evin sarcoma of 6th and 7th rib of with multiple metastases. And his complaint with he came to us with complaint severe shoulder pain, abdominal discomfort with some constipation, and body ache with lower limbs paralyzed with some neurological effects and severe headache. And he complained urinary retention from 2 days, some dribbling or something like that. He's on Pampers. And poor oral intake due to loss of appetite and difficulty in swallowing. And after that, child look very, very ill. It's like a cancer cachexia boy, like that. He's very thin and like that. Next slide. And that history illness, he is diagnosed with 7 diagnosed before 2 years ago. And after that, he had some surgery and they have removed the tumor. And he had undergone chemotherapy, radiotherapy. And after that, he was okay with all the managed cancer treatment. But after 1 year, he had complained some headache and severe headache. After that, we did some MRI scan, CT scan, and after that, we can diagnose some brain mets, and which includes some liver, lung, and all over the body, and bone mets too. And oncologist decided to give some radiotherapy to the brain only. Other than that, we have started some palliative chemotherapy treatment with some pain management. Next. And medications we gave on general examination, on examination, and patient very, very ill looking and severe lymphadenopathy. We can feel that, and patient was icteric and jaundice and very dehydration and vital signs okay, stable, but it's poor volume and things, better palpable. And abdomen tenderness, which child was crying for the pain. He was complaining very, very sharp pain. And we did immediately we did the ultrasound scan. We feel that bladder is full, and we did catheterization for that patient. And we have removed 900 ml urine, and we did some investigation for full blood counts and like that. And patient completely become a neutropenic septic like something, and myelosuppression condition, anemia, and the thrombocytopenia too, and intravenous fluid we started, and morphine 2.5 milligrams subcut stat dose we gave. He was okay with that morphine subcut injection. internet air mattress we put for that patient is paralyzed. Because of that, we want to prevent pressure source and things. Then we apply some intermittent pressure mattress. Next, and psychology. We discussed that the patient is having some problem, that patient can't understand what is happening to his life, but the parents are very so anxious about the patient's children's life and things. And we discussed the parents regarding the current situation and the management, and we have explained them about the patient's critical condition and things. And patient management, pain management, we have modification done for the pain management according to the oncologist's advice. And we arrange some physical comfort for the child. Child wish to have some play things like some video games, and we have arranged all these things to her to be keep happy. And we arrange some practical tasks, like something he has to give some, he want to move but he can't move, but we play with, we put some balls and things, we gave physically, we gave throw into the boy, and we like that we just play. And finally we arrange some spiritual support. As a Buddhist, we ask some give some pretty chant, like something spiritual support. And next, for the medication, subcutaneous alternative, we gave subcutaneous morphine 2.5 milligram SOS, and we continue paracetamol 6 hourly. And gabapentin we gave 75 milligram 12 hourly, and morphine, oral morphine also we gave 10 milligram. Actually, we gave some 5 milligram tablets 8 hourly. Motilium and Emerset IV milligram, 4 milligram we gave for the prevent of abdominal discomfort and the nausea, vomiting. And other than that, we gave dextrose saline, and we, as a combination of say normal saline and dextrose, we gave for the, as a nutrition we gave. Other than that, we gave some parental nutrition to this boy. And we main concern about this patient to minimize the patients and stress of the patients, relatives problems only we got that, because the boy can't understand his life and ending of the life and like these things, and discuss about their financial, they have some financial issues. Our hospital is a private sector hospital, they have to pay more for the treatment and things, and they have paid many things for the chemotherapeutic drugs and things, and they have some financial issues. We discuss, and the main concern of the parents is the financial issue, and prevent bed sores, that we have to give some we have to give more main concern about prevent the bed sores of the boy. And we do some 2-hourly turning, and like that very difficult to turn because of the pain. Just that's why we apply some water bed or something like that, intermittent pressure mattress. And we prevent the constipation. We give some Thermapine, like something with the morphine we have given, as the Sunil has told, that we continuously we gave Cremapine syrup to reduce the constipation, and advice to observe breathing pattern. The parents we gave some advice to, because of the baby is complaining every time the lung mates are there, because of that he's complaining difficulty in breathing. Then we advise relative to be observed about the patient's respiration rates and things. And summary, this child was suffering from having sarcoma and his malignancy tumor aggressive types and not responding to the treatment. And finally, he had some palliative cancer treatment to prevent his complication. But unfortunately, his condition was deteriorated, and oncologist suggests to stop all the supportive treatment except the pain management and symptomatic treatments. Discussion point: how to manage patient anxiety related to losing child. Actually, the parents have some big problem about their child's terminal leave, this condition, cancer like something. It's very difficult to bearable for the patients. How to help them managing their financial condition. Actually, we had some problem with that financial issue. They have the financial issue. We can't help them. And child wishes to go home but unable to take him to this condition. How to help with this? And all these problems we face to and we have discussion, especially we discuss with oncologists about conditions according to this. Thank you.
Thank you, ma'am. Dr. Sunil?
Any of the participants would like to comment on the discussion points? Anybody? What would you do to yeah, another
For financial condition, I think like we can tie up like Ms. Renuka, like you can tie up with some NGOs which could help them. There are like many NGOs who could help them with the supplies.
Yes, actually. But at this moment he is not alive. Actually, 2 weeks back he has already he has gone. But we have some charity or something. We gave some. We arranged some. And in Sri Lanka, actually we don't have much charity service and things to help like that. Even palliative management are not properly managing in Sri Lanka.
Okay, so I think you would be the better person to talk about what you could do in your situation if it was if this was a patient with us. We actually have some funds to help with the patients. Maybe we even provide food kits to patients, and we provide rehabilitation to the patients and families, so that they will be able to manage by themselves. So rehabilitation means it should be depending on the patient and the caregiver's condition. And if the caregiver is expert in something, we will help them to suppose they want to make a petty shop or umbrella making or goat rearing, cow rearing, something like that, so that they will have sustained earning from that rehabilitation. That's the purpose of rehabilitation. Uh, we usually do not give money to the patients as such. We provide free medication, we provide ration for the patient. So that's how we help, because most of the patients who are in this condition will have a lot of debts. And if you are giving money, then that money will be going to repay all the debts that they have had. So it is not better not to give money, but help them in other ways to go on. And as Andavashini told, NGOs are other option, but you say it is not. There are no much such things in your country, and maybe even there are good human beings who could help and even staff members, all those can help the patient if they have a good mind to do that. And managing anxiety related to losing child, I think that's a normal reaction because losing a young member from the family, it will always be painful for the family. And you might have had of grief and bereavement. So this parents will be in anticipatory grief, anticipating that their child is going to die within a few days. That will produce some anxiety and a lot of emotion inside them. So that's a normal reaction. But what we can do is we should openly discuss with the parents. Uh, Probably they might not have had any chance to speak to somebody to vent out their emotion about losing their child. So help them to vent out their emotion and give proper explanation. They might have or they may have more doubts. So we have to have a patient hearing to the parent and find out their concerns about the child um, and then do whatever we can do. Uh, but please understand there is something called as anticipatory grief, which not only in case of losing a young child, but when you lose somebody important in your family, or when you lose some important things from you, then you will have anticipatory grief. You anticipate that the person will be dying in a few days. That will cause many emotions, which is known as anticipatory grief. And child wished to go home but unable to take him in this condition. So can you explain why you were not able to send the patient home?
Beg your pardon, sir?
Why the patient was, why you were unable to send the patient home?
Because I think that they can't manage at home. That they told that parents are told that they can't manage at home because of the baby. The boy is too young and they can't manage actually the parents. They told.
Yeah, that's natural.
We try to send the boy home with the parents, and some we told them to arrange some care or some special assistance, but they refuse and they want to keep the patient in hospital. Because of that, patient was suffering a lot because he missed the home, no, and brothers and siblings are missing and things, no.
Yeah, definitely. So this is a problem that many of the parents will come up with. But we should always be with the patient. We should respect the patient wish. So if the patient want to go home, we should have dialogues with the parents and make them understand that it is important to go home from the child's perspective. And that is the last thing we can do for the child. So we should be able to express from the child's perspective. And they will come up with many concerns. If he has pain at home, what we will do? If he has that thing, what can we do? So you have to actually find out what are the concerns of the parents. Many a times it is if the patient is in a hospital, it's always a support for us, and many things like that will come up. So we will need to give explanation and we need to support them through this difficult time. And even we can nowadays it's a time of telehealth. So even we can see the patient through a WhatsApp call and assess the patient if they send home, and then we will be able to do the needful. And you also need to prescribe medicines, anticipating that this patient may have these problems in the future or when he is going to die. So you will give maybe haloperidol, loaded syringes, midazolam loaded, morphine loaded syringes, and you will ask that, or even you can put a subcutaneous needle like a 24 gauge butterfly, and teach the caregiver how to give or how much midazolam or haloperidol need to be given. And if you have any doubts, call us, and one of you one of you will be calling every day to find out how the patient is doing, and that way we can actually support them. So if they feel that okay, with all this support that we can take the child home, then there is a possibility. But parents are always like this. So it all depends how we communicate, and what is the emotional condition of the parents at that time. I think you did a good job, Renu sister.
Okay, thank you, sir.
So I think if you have any questions on the session that I have taken, you can have 1 or 2 questions, and then we can close the session. Anybody has any doubts?
Sir, regarding this respiratory depression you were discussing, so you were telling like for the few cases, like we need to check whether the patient is having cardiomyopathy or pneumonia or pulmonary embolism. So in that case, we would prefer what type of opioids we could, which is safe for the patient if they're already having this secondary diagnosis.
Yeah, that's a very good question. But some or buprenorphine, which produces or which claims to produce less respiratory depression compared to other opioids. But usually everybody uses morphine or fentanyl. Um, so I think if you titrate morphine or fentanyl in small doses, then it will not cause any problem even for those patients who has cardiomyopathy or pneumonia or any other problems, because many of the patients will be concurrently on benzodiazepines because they are unable to sleep or they have anxiety. So maybe even for a short time they will be on benzodiazepines. So usually it doesn't produce respiratory depression. So I think the most important thing is that you have to titrate the dose. That's what is more important.
Okay, sir. Thank you.
Hi, sir. Good evening.
Yeah, good evening.
Okay, my question was under the topic toxic effect of the morphine. So
Yeah.
one of it is myoclonus, right? So how do you differentiate when the patient already have like a metastatic to brain, and sometimes patient may have fits?
That's again very good question. So how do you differentiate myoclonus from maybe a convulsion due to brain metastasis? So some of the symptoms and signs are of morphine toxicity is delirium, myoclonus, extreme drowsiness, then maybe pinpoint people. But if the patient has a brain metastasis, all of this is possible. Patient can have delirium, can have myoclonus, which can, or a seizure, which can mimic myoclonus. Then drowsiness, which is also possible. Pinpoint people may not be a sign in patients with brain metastasis. It can happen if there is some pontine hemorrhage or something like that. So it would be difficult, but if you know that this patient has been under your care for long enough, then you might be able to pick it up. But as you told, that will be difficult. The only thing, usually the myoclonus is jerky movement of maybe a group of muscles or part of a body or even whole body. So it usually do not look like a convulsion. So in convulsion, the patient will have maybe loss of consciousness even after the convulsion, and they can have very jerky movements, etc. So there would be some differences also. So it would be even though it may not be very easy to pick up, but you will be able to differentiate between these two.
Thank you, sir.
I think we can wind up the session, Rajulakshmi.